Hello, everyone, and thank you so much for joining us again. My name is Precoius McCowan, and I am a 3-time kidney transplant recipient from Texas. I was diagnosed with end-stage kidney disease in 2010 and began on in-center hemodialysis. Since then, as a former dialysis patient, I've committed my life advocating for improved kidney care and advancing research that reflects the real needs of patients with kidney disease. I'm also a donor parent. After the sudden loss of my 2-year-old son, my husband and I decided to donate his organs to be a blessing to someone else. His gift of life continues to inspire everything that I do. As an AAKP Ambassador, an active member of the American Society of Nephrology and the Organ Procurement and Transplantation Network and other organizations, I advocate for better health literacy, stronger policy, and innovative treatments for individuals with kidney disease, and try to make that a priority. Last year, I completed my PhD while having navigating dialysis, a kidney transplant, returning to dialysis, and eventually receiving my 3rd kidney transplant. My research, it focused on African American women with chronic kidney disease. And my advocacy journey, it played a vital role in sharing and shaping my work. Today, I am a research assistant at the University of North Carolina Chapel Hill Kidney Center, a role that was driven by my advocacy for myself and the kidney community. I bring both my lived and professional experiences to the table, and being part of the research process allows me to ensure that patients, especially those from understudied communities, are seen, heard, and represented. I am honored to moderate today's session on the next generation dialysis technology, because patients deserve innovation that makes life not only possible, but better. I'm especially pleased to be a part of this particular event, hosted right here, of course, in the great state of Texas, my home state. So this year's meeting is a fitting title for 50 proud years of patient education, 50 years of saving lives, 50 years of saving livelihoods. The theme reflects both extraordinary process of AAKP that they have made over the years and our continued mission to educate, advocate, and drive innovations that would disrupt the status quo of kidney care. This is precisely why it's my privilege to introduce our session, which I've named before, Next Generation Dialysis Technology, where we are joined by the wonderful Dr. Janice Lee. So welcome, Dr. Lee. Dr. Lee is a master clinician and professor of medicine at Emory University. She's board certified in nephrology and hypertension, and she is the renal division chief, serving over 750 patients. She also holds the position of medical director of home dialysis, currently supporting currently supporting 130 home patients. Her research and her clinical expertise focuses on hypertension, chronic kidney disease, health disparities, and dialysis. Dr. Lee is a nationally recognized hypertension specialist, a master clinician at Emory School of Medicine, and the director of telenephrology at Emory since 2017. On top of all that, she serves on the nephrology specialty board of the American Board of Internal Medicine, and she is a member of the AAKP's National Board of Directors. So please, everyone, join me in welcoming Dr. Lee to present today's discussion.
Thank you so much, Precious. That was a wonderful introduction, and I enjoyed hearing about your journey. It's very inspiring and is what keeps me going to see patients who thrive and want to do better and want to help others. So I'm glad to be here. This is the last session, I believe, right? So what I'd like to do is just kind of give a general overview of where we are with new dialysis technologies. I have no disclosures. Basically, I'm going to start out talking about the basics of dialysis so we can have a good understanding of what the technology entails. So we'll talk about the dialysis access, which you can't do dialysis without an access. We're going to talk about the dialyzer, the dialysis and water treatment, and how much dialysis you use, etc. And all those things will bear into when we talk about the new technologies. So this is a basic sort of cartoon about what dialysis is. And I think it's important for the patients to really know when they're on the dialysis machine what's happening. On one side is the dialysis fluid, and then the other side is your blood. And so when you're sitting in the dialysis machine or peritoneal dialysis, there is a crossover of the bad things that the blood wants to get rid of into the clean dialysis fluid, and that's called diffusion. So it's like if you have a lot of bad substances on one side of the blood, the other side that's clean, the bad things move into the cleaner water. And so that's what diffusion means. And it's the same thing for PD and hemodialysis. And then this cartoon shows that there's two different types of dialysis, but they work together. So one is called hemodialysis, which is on the right, and that's where that diffusion is occurring across the membrane. So what happens is your blood comes in one way, the dialysis comes in, fluid comes in another way, and they mix together in that filter that's on your dialysis machine. And again, that diffusion occurs across that membrane. On the other side is something we call hemofiltration. And that's also happening during dialysis, but there's some new technology that is making that a bigger part of what dialysis is. And basically it's called convection. And that's when water moves across the membrane and then solutes, other substances that the body wants to get rid of, move with the water. And it's a pressure gradient to make that happen. This is another cartoon. I like to show a lot of pictures so everyone really understands what we're talking about. So this is the inside of the dialysis filter. And you know, when you go get your labs done, you want to know what your potassium is, what your creatinine is, what your urea or blood urea nitrogen is. And see, that's what's showing here, and that's what's inside, and then it's moving out into the dialysis fluid that then comes out of the patient, and that's the cleansed blood. This is another cartoon looking at the entire process. This is the blood coming from the patient. It's called the arterial side, coming in to mix with the dialysis fluid that's coming here. And then all of the bad things are coming out in what we call the effluent. So that's where all the waste products are coming out. This is more of the hemofiltration that occurs. So in this particular diagram, we don't have dialysis fluid that's mixing in the filter, but we have convective pressure that is moving that water and other substances out into the effluent that is listed here. And that again is called convection. And then this is the sum of all of what we just said. It says CVVHDF. And this is for patients that are doing continuous dialysis in the hospital, or another word is CRT for you who are familiar with that. And it's a process of diffusion and convection. And that's when you have the dialysis fluid that's bathing the blood in the filter, and then you have the convective clearance that you have to send replacement fluid to the patient because you're taking a lot of fluid out to generate that force of pressure to remove solutes and other particles. So you have to replace the fluid to the patient because they would have problems with their blood pressure dropping if you did not replace it. So this is one of the first new technologies that is now available. It's being used in Europe, but it's now being used in the US, and it's called hemodiafiltration. So what they're doing is adding the convective part to the dialysis that you're usually used to. And then this is depicted again on this cartoon. This is the filter. And you have convective clearance that's generated by a pressure that sort of sucks the water out. And it's lots of water. It can be like up to 20 liters of water. And that also clears molecules. And then you have your usual diffusion, which is the substances that are transferring across the membrane. So the urea, the creatinine, and the potassium. And then this is the whole system sort of depicted here. This is the patient here, the blood coming out, going to the dialyzer, being bathed with the dialysis fluid, toxin removal, but you also have the online hemodiafiltration that generates a substitution fluid that goes back to the patient after you've removed all of the water and other substances. So this is what we call online hemodiafiltration, and some clinics now are using this to get better clearance. Now you might ask, what's better about this? So these are all the major kind of molecules that the kidney normally sort of excretes, and this is what dialysis is removing. And you can see basically things move across the membrane according to their size. So large particles cannot get through the basic dialysis filter. Smaller molecules like phosphorus, urea, creatinine do move across, and that's why dialysis is efficient in removing those. But you can see there's a whole list of other type of solutes and proteins that are much larger. This is the molecular weight in grams per mole. The typical filters that we use for, especially for in-center dialysis, do not remove all of these particles. And so what hemofiltration does, because it's applying a large pressure gradient, sucking a lot of water out, it is able to remove larger solutes. So that's what the big difference is between regular dialysis and hemodiafiltration. Now, you might ask, what are these substances? Has anyone ever heard of beta-2 microglobulin? Has anybody heard of that? It's not on your lab report, right? Beta-2 microglobulin is a protein that is in our system, in our blood, and when it builds up, it can cause cysts in your bones. It can cause deposits of amyloid. It's a protein in your tissues and causes joint pain. And the other big thing that it causes is carpal tunnel syndrome. So I've had patients who've been on dialysis for 20 plus years, and they have numbness in their hands. And it's not because of their vascular access. It's because of these amyloid deposits that deposit in their nerves in their hands. And so this particular treatment is better equipped to remove this molecule. So for patients, and this happens in patients who've been on dialysis a long time, that beta-2 microglobulin builds up because it's not taken out with the regular way we do dialysis, and can cause this. I've had patients who just had severe pain and numbness. They couldn't do anything with their hands, and it was just because of this molecule. And this is just another way to kind of look at this. These are the smaller molecules that we remove with regular dialysis. And then you have your B12, inulin, beta-2 microglobulin is here. Look at this blue line. This is the normal kidney working at about 100%, removing 100 mils per minute of toxins from the blood. The green line is the hemofiltration. So see, it's really close to what the blue line is doing, your native kidneys. So this is a real promising therapy because we do not know all of the damage that all of these other toxins are doing to our system. We know the ones that we measure routinely, but there's a whole host of factors, even beyond the ones I have listed, that can actually damage tissues in our body. This is the regular dialysis that we do, and you can see is very high for clearing urea creatinine, but when you get to these larger molecules, it dips off. Okay, so that's really kind of the big difference between just dialysis and adding the hemofiltration. Does anybody know what this is? It's a cartoon for the dialysis membrane, the filter that's in your dialysis, where your blood goes through. And I just wanted to show you this because it shows you the spaces in between. That's where the molecules move throughout the dialysis session. You can see it here. It's moving from one side to the other through these pores. And you can see some of the pores are smaller than others. This is a bigger pore, and those are smaller pores. And so like if you're at the dialysis center, you may be on F180. Does that ring a bell, that number? 180, you could do a 200, a 210, and a 250. The bigger that number is, the bigger that pore size. And so that means it can remove bigger solutes and more solutes per time of the dialysis treatment. Now, the big question is this new therapy beneficial? What have the studies shown? This is from the previous diagram that I showed you from hemodiafiltration. So that's what HVHDF means, and then this is regular hemodialysis. And you can see that there is a benefit in death outcomes. The patients treated with the filtration plus dialysis have a lower death rate than those who don't. There's some other data. It's still being really studied and looked at. There is some data that suggests that some of the quality of life is better with the hemodiafiltration, and especially around the area of cognitive function. But I think there's a lot more technology and outcomes that we need to learn about that process. Now I wanted to transition quickly to home dialysis, and I always like to show this slide. This was a question sent to dialysis physicians and nurses about if they had to start dialysis, what type of dialysis would they want to do. And you can see there's an overwhelming 90% response rate for doing a home modality. Only 6% said they would choose in-center. But guess what? It's the opposite for the patients. They're the ones that are doing 90% in-center and less on home because they didn't have a choice. Certainly, I think we've come a long way with education and advocacy for home dialysis, so those numbers hopefully will be better, continue to get better in the future. This is just an example of a home dialysis setup. You see the machine here, and we call this low volume platform. It's not using nearly as much water as the big machines that you use in center. And this particular device is the next stage machine that many of you may be familiar with. But the new technology, which has been around a couple of years now, at least, probably 5 years, but it's not been as penetrating into all of the market, is using an iPad. And I was talking with one of the participants here, Fred, who used to do Next Stage at home, and when he did it, he had to write down all of the blood pressures and all of the treatment parameters. And he was excited to know that you now have this iPad and it's connected to the machine. And so all of the data is recorded through the machine and can be sent to the clinic. The nurses can log in and see what's going on, see if their patient did their treatment like they were supposed to, all those types of things. So I think we're definitely improving with the technology to make home dialysis easier and more efficient to do at home. This is the same setup. This is the pure flow system that patients have in their home, so they don't have to have all of the bags that are hanging here. And again, the newer technology is to use the iPad. There are other home therapies available. And here, there's different machines. This is the next stage that I just showed you. This is the Tableau. I think many people have heard about the Tableau. That's what you use? Okay. You like it? Oh, okay. Okay, good. And it's a lot more user-friendly, but the problem is it's not used everywhere, right? Because of cost. Yeah, it's limited. But we do have options. I'm going to talk about some of this later. Just a quick thing on quality of life. I think everyone in here can attest to this if you've been on home dialysis, and this is whether or not you're on PD or home hemo, that you feel less drained, less fatigue. You don't have to, I know for in-center patients, they feel like when they go home, all they do is go to sleep, right? They're so drained, they can't do anything. With home dialysis, because you're doing more often and less intensity each day, you feel like you can still do things, you still have energy. You usually don't have the massive fluid shifts that you occur with a shorter treatment, so you have less headache, less nausea, etc., less hypotension, and then improved quality of life. So I'll never forget, I have a patient who's was doing in-center. He decided to do home. His wife was helping him. And the wife, like about a month into it, said, "Dr. Lee, I wish you would have put him on home dialysis sooner. He's now going home and cutting the grass and everything after dialysis when he couldn't do that before when he was in center. So it definitely improves quality of life. Now, PD, I think anyone on PD knows the biggest problem is infection, right? Peritonitis. And that's what's illustrated here. Almost 30% of patients who have to stop doing PD is because of infection. So is there any technology that could help us with that? So yes, there is. I don't have a picture of the device, but I can tell you what it is. And this is, of course, the peritoneal catheter that's going into the peritoneum. And we all know that you have to disconnect this catheter to attach it to the fluid, whether you're on the cycler or the manual exchanges. So there's a device that you can put here called the Peritoneal X. Is one of the devices. I believe there's a couple of these. And what it does is disinfect the tubing after you make your connection. So it'll be a solution that's sort of instilled in that area for a little bit of time, then it's drawn back out. And it's supposed to help reduce infection with the disconnect and reconnecting process. There's also something, and there's a couple of these, something called Optic Line is one of them. There's about 2 or 3 that are being studied. They're point of care devices that actually patients could have in the home and see if they have an infection brewing in their peritoneal fluid. The way we do it now is we have them tell us if the fluid's cloudy, and then they call the nurse and then they have to come in, etc. And that may be a delay in that process. But with this, they can actually use it at home. It's like a dipstick, and it lights up if there's an infection, basically. And then they can let the nurse know, make arrangements to get whatever they need, antibiotics, get the culture done, etc. There's some other sort of exciting PD technology on the horizon. It's being studied now. There's a couple of devices that can regenerate the PD fluid. So you don't have to have all of those bags. And I know some of you know how much storage that takes to have all the dialysis fluid bags stored in your home. So there's 2 things. There's one way to regenerate the dialysate that was already used. It is put through a carbon filter and all the impurities are removed, and then you make fresh dialysate that can go back to the patient. Or you can do on-demand solution generation, and I think that one will probably be the biggest one, because you're not reusing anything. It's going to be fresh dialysate, and it only takes a little bit of concentrate of dialysis fluid and water, and the machine generates the fluid. And so that will also require less storage of bags of dialysate. And then there's these portable devices. This is one type device that's wearable, and it uses sorbent cartridge technology, again with the carbon, to regenerate the dialysis fluid. And so a patient will have an external device that connects to their peritoneum. And again, they won't have to have bags of fluid. It will regenerate the dialysate and cause them to be able to continue dialysis without the need of large bags. Now, I think this is particularly important because we all know what happened last year with the PD fluid shortage, right? That was a disaster with the hurricane and the flooding and the Baxter plant that was destroyed, basically. And so it limited the production and use of PD fluids for the patient. So having this type of technology, when it comes into fruition, will be a tremendous advantage to allow us to not have to deal with those types of disasters again. This is just, whenever you talk about innovation and technology, I think telehealth is a big piece of that. And all of the new technology is incorporating some form of remote monitoring, telehealth, the patient being able to connect to their providers. And I think that's so important. And I think it's important even with our current infrastructure. For example, if a patient is too sick or they can't make it to the clinic, they don't have transportation to see the doctor, we can see them with the telehealth. We still are able to do that. And that's a tremendous, I think, benefit. And nurses can follow up with the patients, look at their exit sites, et cetera. So I think we will continue to use that. Now, I wanted to just quickly show you a couple of vascular access innovations. I met someone here who has an endovascular fistula. I don't see her right now. But everyone who's been on dialysis and had grafts and fistulas know all of the pitfalls and limitations with that. First of all, it's a surgical procedure. There's risk of infection. There's risk of thrombosis, veins narrowing, etc. And so it's exciting that we have some new devices. And I'm not promoting either of these. I'm just letting you know what's out there. There's the WaveLink endovascular fistula device, and then there's an elliptus one, and I'll show you that one in a minute. But basically, instead of having open surgery where there's a cut to manually put together the patient's artery and a vein, it's done through this catheter. So it's done through the skin, going directly to the vein and artery, and fusing them together with thermal energy. And that's how it's done. The problem with, well, one of the limitations with this one, it takes 2 sticks. So you have to go into the artery and a vein with the catheter. The next one is the ellipsis device, and it's a single device. So you go in one time, and it uses radio frequency energy. And here's an example of an artery and a vein that are joined together with this device to look like that. So it's no scars, it's no sutures, it's all done via that catheter. And these have better outcomes. They're usually last longer, more effective, and less issues with it developing or maturing properly. This is another kind of interesting device called the OptiFlow anastomotic device. This is the typical vein and artery that's sort of tied together. That's what the anastomosis means. And you can see already it's a little bit narrow there. So over time, that may get worse and the fistula may not work. But here they use a conduit that they put into the artery and vein, and see how wide open that is. So that's another exciting technology. I have not heard a lot about how well it's doing or what the uptake of it is. I know the endovascular fistulas are, I think, a little bit more widespread use. And this is just a graft. If you've never seen what a graft looks like when they put a graft in your arm, it's just a piece of tubing that you connect to the artery and vein. And I don't know how well you can appreciate this, but there's some tissue that's sort of on top of that graft. And that is like scarring and fibrosis, and that with time, that graft is gonna not work. And so there's technologies to actually apply certain types of medications that inhibit cell growth to inhibit that production of that tissue around that graft so that it won't thrombose. And this is just something that was presented at a vascular conference where they kind of had all of the newer sort of experimental type therapies that they were looking at, and these were some of the top ones. So really interesting. They're working on a wearable telehealth device to monitor for thrombosis and the health of the fistula. So before a patient actually clots, there'll be technology to help predict that. So I think that's pretty fascinating. Now, this is just a cartoon about the artificial kidney. And I know you all have heard about this. They've been working on it for years, right? I mean, I don't know when it's going to come into real practical use. But it's actually a kidney, a filter that's implanted internally that will have the properties to be able to cause diffusion and removal of the toxins. They're also working on it to provide metabolic function too. So we all know the kidneys do more than just clear toxins. They make different hormones. Remember how we have to take, or not me, but you all have to take vitamin D because the kidney makes vitamin D. You have to take EPO. The kidney makes EPO. And so if you're with the regular dialysis that we do, we're only cleansing the blood. We're not providing those other functions of the kidney. So the artificial kidney is working on that to provide all of that so that the patient can have normal, pretty much normal kidney function. Yeah, and this is a picture of the device that I was telling you about, the artificial portable dialysis, where it's connected to their vascular access, and there's a carbon filter on the outside that's causing whatever waste products come out to get regenerated and cleansed, and then using that as a source to have continuous dialysis. So the summary here is that there are ongoing studies and development going on for new dialysis technologies. However, as we've heard in several talks earlier, cost is a big issue, lack of research funding, and just slow approval processes by the FDA, et cetera, to get those to the patients in a timely manner. But there are things that people are working on, and I think it's important for groups like AAKP to continue advocacy efforts so that we can continue to bring innovation to the renal community. And I always like to end with this slide. As Dorothy says in The Wizard of Oz, there's no place like home. And I think most of you can resonate with that message. And you know, we want to try to get more patients at home. And then patients engaged in their own care have the best outcomes. So learning about your disease, knowing when to ask questions of your providers, and how to advocate for yourself that you get the best treatment that there is to get. And then I will close with that, and that's my email address if anyone wants to ask me any questions later or today. And thank you very much.
So thank you so much, Dr. Lee, for that very informative presentation and also just sharing with us your passion for patient care. So thank you. So we have time for a couple of questions from the audience, and an AAKP team member will come to you with the mic. But while we wait, Dr. Lee, I want to ask you a question. So how can patients best partner with their healthcare team to ensure that they're making an informed decision when new dialysis technologies or treatments become available?
Yeah, well, that's why, you know, these types of seminars are important, so you can learn about what there is, because some of you may know about things and the doctor may or may not know, or there may not be proponents of home therapies, et cetera. So you have to advocate for yourself. And I mean, I've had patients come to me and ask me about certain medications. You know, they see it on TV, right? And then I'll explain why I think they may not be a good candidate for that. But as far as dialysis, and you know, different dialysis companies have different equipment, et cetera. Some use their own equipment, some use others, and they may not have access to all of the equipment. And so you need to ask about it and ask them what they think about it. If they say, no, we can't do that, maybe seek out another clinic that might have it, you know, so you have to advocate for yourself.
Okay. Great
I
answer.
have a question over here.
Thank you for your time. You were talking about the new therapy dialysis. Is there a difference now on time limit? You mentioned that now they can filter out more. Is it now, instead of doing 5 hours, you can do 4.5 hours or 4 hours? Is that something with the new therapy?
Yeah, I think you mean for the hemodiafiltration that
Correct.
you do in center?
Yes, correct.
So I'm not familiar with many centers doing more than 4 hours in general. Okay. If they're doing 5 hours, they're probably on nocturnal shift, but I have not heard of any change in the time yet, that it'll be a faster treatment. I haven't heard that. The data that I showed you wasn't substantially lower time.
And the other question is, now that you said they're doing it here in America, in the U.S., do you know any centers here that have the equipment? Or is the equipment an added cost for these centers now that they would have to spend before they get this equipment to share it with us?
Yeah, so the machine is made by Fresenius, and they make a lot of the in-center dialysis machines. So I'm aware that they're in the Fresenius clinics right now. And of course, they're products, so they probably have better whatever cost, et cetera. But I can tell you it will be a limitation in some other clinics because they're going to cost more.
Okay. Thank you so much.
Sure.
So another question about hemodiafiltration and some of the newer platforms. Is KT over V still the gold standard? Do you foresee anything in the future that might replace KT over V in terms of dialysis efficiency?
So that's a very good question. There's a lot of debate about whether or not KT over V is the right marker that we should be using to determine adequacy. And that's why this newer therapy, which is removing larger molecules that we don't measure, and we don't have a way to calculate how well it's being removed, it's thought that those larger molecules are also contributing to outcomes and our mortality outcomes, et cetera, but we don't measure them like we measure KT over V. Right now, I do not see that the KT over V will go away. I'm also told, because I asked this question directly to the company that makes the machines, if you run the patient the same time with dialysis versus hemodiafiltration, the KT over V is still the same. And that's because this new technology is removing larger molecules. It's not enhancing the movement of the smaller molecules, which is what we measure. So, but I do think in the future, there will be more of a push to not just focus just on KT over V.
Any more questions from the audience? Can't tell. Okay, so this concludes our session and event, and I would like to thank Dr. Lee again so much for informing us. I would like to thank you all for joining us.